audiences and our moderator. First of all, I would like to thank to all our distinguished speakers who are willing to come and give us lectures for the YNS group. And today, before I start, I think I wish to inform those who may not obtain the news regarding the passing of our one of the founding member of ACNS. Is the founding president of ACNS, Emeritus Professor Tesukwano, who passed away 2 days ago on 6th of August due to a heart problem. And I wish to request for 1 minute of silence for our respect to him. We can start now. Sorry. Thank you to everyone. I think over the past 2 days, we have received quite a number of messages from our friends, colleagues, and we shall gather all those tribute, and we will put all of them in our website soon. And our professor is here, Professor Kato. Thanks for coming and joining us, Professor Kato. We would call upon Professor Kato to give a short opening remark before we call upon our speaker, Professor.
Thank you for the invitation at this time again. So first of all, I'd like to inform my very sad the news. Of course, everybody knows already that Professor Kano has passed away the last Friday at the age of 82. So he fell on 2 weeks back at just in front of his house. Then after that, he recovered a little bit, but he has some his own disease. So I think so last 2 days he was intubated, and maybe everybody think the final reason is some cardiac valve failure, I think. But I think that he was very, how to say, very active and always encourage us. And also his outstanding stamina for teaching everybody, not only the younger generation. We should follow his step, I think, as much as possible. We cannot get close to him, but we can do our best. And for the future education of the YNS. I thank you very much, all of you, taking care of the Professor Kano until the last moment. I think his face was very peaceful, very, very peaceful at the last moment, I think. So please don't worry. So today is again YNS. ACNS YNS, the webinar will start. Today again, the very fantastic, the 2 guests, no, 4 guests as speakers. So I think we can expect the talks. Thank you very much.
Thank you very much, Professor Kato. So today, as what Professor Kato had mentioned, we have 3 distinguished speakers, Dr. Ame, we have Professor Benz, Professor Wada, and we have 2 YNS speakers, Dr. Reddy and Dr. Gretian. We also have four moderators with me now, Dr. Angela, Dr. Fahmi, and Dr. Ishu. So each of us, we introduce one speaker each. So I would like to call upon our first speaker. He is Dr. Amir Qureshi. He is a consultant vascular and skull-based surgeon based in Nairobi Hospital in Nairobi, Kenya. And he did his residency at the University of Cape Town, which a student under Professor Alan Taylor for open vascular and endovascular subspecialization. And we are fortunate for him to join us, and he will talk on development of the carotid and vertebral basilar system. Welcome, Dr. Amir. You may start your lecture.
Thank you very, very much, Dr. Boone. I would just like to share my screen, and I hope you're able to see it. Are you able to see this screen?
Yes.
It says neurovascular development. Before I start, I would like to personally just thank Professor Yoko Kato, who I've known for several years. She has really been one of my personal mentors. And I've sort of met her several years ago when I was first doing general surgery, and she was one of the very special people that helped move me towards neurosurgery, and really much of what I've done in neurosurgery has actually been through her personal efforts in her teachings and her trainings. There are a lot of people that have actually benefited from what Professor Kato has done, and really saying thank you is not enough. But I would just like to start by saying thank you very much, Professor Kato, for this kind invitation. Now, this is going to be an animated talk, and the reason I thought about speaking about it was, and essentially when I went through my residency, the vascular system was taught to me, but I never really understood how it was formed. And only when I got into my fellowship with Professor Taylor, who was a student of the great Professor Pierre Lazunius, many of these concepts started to come into me, and it took a little bit of time for them to make sense. So what I did is I made an animation to help me understand, and I hope through this animation I will be able to help some of the other young neurosurgeons and understand these very crucial concepts. This is a very basic talk, but I hope that it will help stimulate us to sort of go and read and build up on it. But this I thought was helpful. So this is going to be a story, and I'm just going to minimize one of these and let this story begin. So really, our central nervous system starts off like this, a very simple neural plate, which folds up to now become a neural tube at about day 24 to day 28. And that early neural plate, and indeed the early neural tube, relies on simple diffusion for it to obtain its oxygen and nutrients. But as metabolic demands grow, the simple diffusion cannot cope. So it starts to now develop its own very primitive vascular system. And that primitive vascular system initially starts from the surface of the neural tube, from cells known as the minix primitiva. There's angiogenesis that happens here, and angiogenic clusters form very primitive little tubules without an identity. So they're not arteries, they're not veins, but these help to bring early perfusion through to this neural tube. Now, as the metabolic demands grow greater, 3 paired vessels form ventral to this neural tube, the closest being the longitudinal neural system, which arises from the minix primitiva. This will now give rise to the future vertebrobasilar systems, as we will see. Ventral to that, there are paired dorsal aortas and paired ventral aortas. Now, these arise from that very early truncus arteriosus as it starts to now develop and give us the early developing heart. Now, there are 6 pharyngeal arches that now develop from this primitive neural crest, which link the dorsal aorta and the ventral aorta. Now, I've only brought out 3 because for the purposes of now developing the internal carotid, we really look at the first 3 arches. There are primitive connections that form between the longitudinal neural system and the dorsal aorta. The most commonest one that we may have heard of is the primitive trigeminal, but these regress and sort of disappear very early on, as we're able to see here. Now, those regressions happen after this very important posterior division forms. And this is important. This posterior division will link the dorsal aorta to the very tip of the longitudinal neural system. Its counterpart, or the anterior division, moves off to now start, and it gives perfusion to the growing prosencephalon. And from that, we have a ventral ophthalmic artery that starts, to now form. Coming off the distal end of the dorsal aorta, we have a ventral ophthalmic. We also have a dorsal ophthalmic artery, and we will look at where this vessel then leads. Below that, we have the primitive maxillary artery, which goes to now perfuse the very early Rathge's pouch. So this picture that we're able to see here is really the very early vertebrobasilar system. Now, this is not the situation in man as we know it now. Phylogenetically, there's a whole change of things that happen, and let's start now breaking up those changes. We know that posterior division will change its name to now what we know as the posterior communicating artery. The anterior division to the prosencephalon we now call the anterior cerebral artery. The dorsal aorta below the third arch will involute. And that involution causes a change in blood supply coming through that ventral aorta, the third arch, and up into the dorsal aorta. The ventral aorta below the third arch, we now start calling a common carotid artery, and the third arch and that distal dorsal aorta below what has regressed, we now start calling the internal cerebral artery. So this is a very primitive picture now that is starting to form. There are important connections that form between the first and second arches, followed by very important regressions, as we're able to see here. Now, one of those little stumps that's left of the first arch becomes the mandibular artery, and that also regresses. And this remnant of the first arch, with its now important connection to the second arch, forms the hyoestopedial system. And we'll look at this hyoestopedial system in greater detail in a subsequent slide. From the very tip of what was the ventral aorta, we have the ventral pharyngeal arteries that come, and this is the early precursors for essentially the linguofacial system. And further connections start to form. That ventral ophthalmic artery, and we'll see in a subsequent slide, regresses and almost moves more proximally to give us the ophthalmic artery proper. The dorsal ophthalmic artery will now change to give us the infralateral trunk, and that primitive maxillary artery now gives us the posterior inferior hypophyseal artery. So this is where those early arteries now start coming from. If I change this picture just a little bit, and if we concentrate on this part here, we have the internal max, the middle meningeal artery. And if I look at this system here, what is this? This is really the primitive external carotid artery starting to now form. So this is important. We will focus most of this talk on the internal carotid and the vertebrobasilar systems. So now let's look at some of these early arteries that seem to have regressed away. Why are they important? Because when we look at them and where they're essentially positioned, they will now give us 6 segments of the internal carotid artery, with each of these primitive vessels forming a junction from one segment to essentially the next segment. So here we have them. Our first carotid segment is now a cervical carotid. The second segment is what we refer to as the ascending petrosal segment. So it's just going through the petrous bone. The third segment is now the horizontal petrosal segment. The fourth segment flows over foramen lacerum, starts to enter that very early cavernous sinus area. The fifth segment is the horizontal cavernous segment, and that last sixth segment is the clinoidal segment. Now, why is it important to look at it in this way? There are very many ways of classifying and naming the internal carotid artery, but this makes the most sense from a developmental standpoint. For example, if there is agenesis of the first and second segments of the internal carotid artery, then this caroticotympanic artery simply will reconstitute the distal internal carotid artery from the external carotid. If the fourth segment does not develop well, the primitive trigeminal coming from the longitudinal system or from the vertebrobascular system starts to give supply to the distal internal. The sixth segment being absent, the ophthalmic artery brings in supply from essentially the external carotid, and we'll see that in some subsequent slides. Let's look at this stapedial artery that I mentioned about, and I'm going to put in a few foramina here. We'll start with the carotid canal, foramen spinosum, and the superiorbital fissure. Here comes the internal carotid as it loops, gives us that loop of the cavernous segment, and from its proximal part, its proximal intracranial part, we have the hyoid artery. From that hyoid artery comes the stapedial artery, which we saw forming between the first and second arches. Now, this stapedial artery has a superior ramus that comes to now supply the early dura and goes through the superior orbital fissure to give us the orbital branch supplying the adnexa of the eye. There's an inferior ramus that comes through foramen spinosum and comes to anastomose with branches of the ventral pharyngeal through what is seemingly called the maxillomandibular artery. So let's look at blood supply coming through that stapedial artery. We know that blood comes in, it goes down foramen spinosum, and this early stapedial artery is involved with supplying non-neural structures of the face. So it comes down through foramen spinosum, supplying the face. It also gives blood supply up through the dural and the orbital branches, as you can see. But as that artery regresses, and this is important, there is a change in essentially the flow of blood. So now blood comes through the ventral pharyngeal trunk into that inferior ramus to give supply to the dura and through to the orbit. That maxillomandibular artery changes name, and when this reversal happens, we simply start calling that a middle meningeal artery. So we can see that the middle meningeal artery can have supply to the orbit, and we know it supplies the dura. This happens after the stapedial artery regresses. If I look at the ophthalmic artery, I'll put in the optic canal there, put in the early eye with a lens and a small optic nerve. We know that the ventral ophthalmic comes from the anterior cerebral artery, and that goes through the optic canal to go and supply structures within the orbit and the eye. There's a dorsal ophthalmic that comes in through the superorbital fissure and comes to anastomose with the ventral ophthalmic to also supply adnexa of the eye and can be the supplier of the retina too. Now, we had mentioned earlier that this dorsal ophthalmic artery gives rise to the intralateral trunk. And let's see what happens there. I've just put in some foramina from the optic canal, superorbital fissure, foramen rotundum, and foramen ovale. This is the internal carotid artery, just zoomed up over that cavernous segment there. We had mentioned the ventral ophthalmic artery, and we had said that this artery seems to almost regress and migrates more proximally to give us the ophthalmic artery proper. The dorsal ophthalmic artery gives us the proximal aspect, gives us the infralateral trunk. The distal aspect gives us the remnant of the deep recurrent ophthalmic artery. And this is an important anastomotic branch coming from the orbit into the infralateral trunk and can supply the carotid if there is proximal agenesis of the carotid in that area. There are other branches that go through foramen rotundum, and they come to anastomose with branches of the internal max. Branches going through foramen ovale will also anastomose with branches coming from the internal max, in this case, the accessory meningeal. There are branches that come more posteriorly to anastomose with the stapediocollaterals or the middle meningeal, and lastly, branches that come through foramen lacerum to anastomose with branches of the ascending pharyngeal. So here we're able to see that although the infralateral trunk, which we barely see on just normal angiography, it may just be a very small vessel, it has very many important anastomotic channels that end up becoming very relevant when it comes to angiography or dealing with tumors in this region. I would just like to show you some internal carotid injections. These are sort of lateral, these are lateral injections of the internal carotid. This is the dye going in, and what are we seeing? The ophthalmic artery filling, and this is what I want to show to you if you're able to see my arrow. This is called the choroidal blush, and this is really the retina receiving blood supply from the ophthalmic. And this is the ophthalmic of a child that was having some intraarterial chemotherapy for a rare retinoblastoma. In this next child, the same internal carotid injection, but we do not see ophthalmic filling and certainly no choroidal blush. The question is, where is this child's eye getting perfused? From our talk, we've seen that this can come through the middle meningeal artery, and indeed, sort of a lateral run of the external carotid, we're able to see the anterior branch of the middle meningeal giving supply to give us that choroidal blush there. So in this child, the orbit, the eye itself and the retina was being supplied by the external carotid. I would like to just move from there to a summary of the vertebro-basilar systems and the vertebro-basilar junction. Now, early in evolution, we all started off as segmental creatures, similar to an earthworm. And indeed, we had segmental blood supply. Now, as phylogeny happened and as the species evolved, they then became very many important intersegmental channels that started to form. And what I've laid down here is the middle line, or number one being the midline longitudinal system, which would correlate to the basilar artery and to the anterior spinal in one axis. The paramedial longitudinal system being essentially the lateral spinal artery. We don't see them intracranially, so you won't see them in this slide. And our third line being essentially the longitudinal intersegmental anastomosis, which essentially would correspond with the vertebral artery system. So as we start forming those intersegmental channels, because of these channels forming in our blood supply, we no longer require complete segmental vessels. And indeed, those segmental vessels start to regress with the formation of intersegmental channels. And as those regressions occur and further intersegmental branches start to form, this is what gives us, and essentially in our textbooks, the adult pattern of the vertebro-basilar system. We will talk about the ICA and PICA in one of our last slides, but this is really the sort of textbook pattern that we see that forms when certain segmental vessels will regress, and whilst the intersegmental vessels form. It's very easy to see that if there is if there's partial regression or over regression of one of these vessels, we then start to form variants, and I'll show you some of those variants now. There is our anterior spinal in that midline longitudinal neural system. So let's just look at some of the variants that can happen around the pica, or the posterior inferior hypophyseal artery. So if the pica regresses and an intersegmental channel comes from the ICA to supply the distal segment of the pica, we would simply call that an ICA-pica, meaning that the ICA has taken over the pica territory. In this scenario here, we have an intersegmental vessel coming from C1, and this would be a C1 pica, so the pica being supplied from the C1 segmental vessel. In this variant here, we have a segmental persistence at C2 with an intersegmental vessel at C12, and this will give us a vertebral duplication at C12, with the lower one being a sort of a second little vessel that runs an intradural route. So it's important to know this when one is opening the dura in that area. Let us look at one of our last ones here. Here we have a segmental remnant of C2 with the segmental remnant of the pica and a vessel that now links them. And here we have a very rare C2 origin of the pica and a hypoplastic vertebral on that side. Let's see what happens here. Here we've now got a vertebral origin of the pica straight from the vert with an absent distal vert. So these are all variants that can occur around that pica region just because of the way the segmental genesis happens and how the intersegmental vessels form. These are pictures that are courtesy of Philip here. Here on the left side, I'd like to show you the classical pica, so the pica that is coming off the proximal vert, and it's going to now supply the brain stem. I want you to keep that in mind, supply the brain stem. Here in the middle picture, we have an Ica pica, so a very large Ica coming down and looping down towards the pica territory, with essentially the perforators to the brainstem now coming from the vertebral artery. And in our picture on the right, it's been cut there, but this pica has originated from C1. So these are different anatomical specimens that have been prepared by Philip Mercier. Now, nearing the end of this talk, there are two more slides, but I would like to talk about dedicated vessels to different parts of the central nervous system and more sort of cranial parts of the central nervous system with sites of carotid vertebral vascular anastomosis. So what I'd like to draw here is really the secondary brain vesicles, the primary ones now giving us 5 brain vesicles, and we'll simply name these, starting with the telencephalon, the diencephalon, the mesencephalon, the midbrain, the metencephalon, and the myelencephalon. We'll put in the internal carotid artery, and as it comes to loop up and now connect with the longitudinal neural system, both lying ventral to this. We know that from the anterior cerebral, like I mentioned, it really goes to supply the telencephalon, or that forebrain, a very important vessel. Now, here is an important point. As mammals evolved, and as essentially we came from reptiles to birds to mammals, the very early animals had a basal ganglia system that was being supplied by lenticular striates that were arising from the anterior cerebral artery. And as the hemispheres or the forebrain began to grow in mammals, some of these perforators or these lenticular striate vessels started to obtain cortical territory. They started to capture the cortical territory. And indeed, if you look at us, we have one very large perforator that comes to capture cortical territory. This large perforator we simply call a middle cerebral artery. So the middle cerebral artery is nothing but a perforator that has evolved over hundreds or millions of years to now capture cortical territory, and has now, because of the biochemical demands on this vessel, has now become very large. So the anterior cerebral and middle cerebral are suppliers to the telencephalon. The supplier to the diencephalon is the anterior choroidal artery, a very important vessel. Supply to the mesencephalon or the midbrain comes from the posterior choroidal, and the posterior aspect of the mesencephalon is now supplied by the collicular arteries, giving supply to the tectal plate as we know it. Then the metencephalon, the pons, and part of the cerebellum get supplied from the superior cerebellar artery and from the Ica, and the medulla is supplied by pica. Now, we've always learned that the pica goes to give supply to the cerebellum, and indeed it does. But from an evolutionary standpoint, that was never really the case. As the cerebellum developed, it almost annexed the supply of the pica and called the pica to it. But why is that important? That means that the supply to the medulla will always come from the pica, and will only not come from the pica if you have a C1 pica, for example, or if you have an ICA pica. And that's important when it comes to dealing with tumors in that region around the foramen magnum. Let's look at we had mentioned this very important link between the carotid and the longitudinal neural system, which gives rise to the vertebrovascular system called the PCOM, and other links that regress but can continue to stay: the primitive trigeminal, the otic artery, the hypoglossal artery, the C1 for the proatlantal 1 at C1 and a proatlantal type 2 at C2. Now, these lower vessels, as I mentioned, regress, but if there is any sectional genesis of that internal carotid, then these vessels are sometimes persist, as we can see in this slide. Here we are seeing the distal end of the bacilla being supplied by this vessel that's coming just proximal to the cavernous segment of the internal carotid. That is a primitive trigeminal artery going at, to now supply the posterior cerebral artery territory. So that's what I'd like to share with you for now. Thank you very, very much. And I just hope that with some of these basics, we should be able to build and on that. Thank you very much.
Thank you, Dr. Amir, for very fascinating and very interactive lecture. Is there any question? If not, we move to the next speaker first. I think we leave the question to the last. Dr. Angela, can you please introduce our next speaker?
First, that was a great talk. Thank you so much. Our next speaker is Professor Vladimir YNS. He is the professor and chairman at the first medical faculty of Charles University Prague, and also I believe Central Military Hospital, University Military Hospital. He belongs to many organizations and has been the president of the European Skull-Based Surgery Society, the president of the International Meningioma Society, has membership to many American and European neurosurgical organizations, and served on the editorial board of a large number of journals. And today he is going to be speaking to us about arteriovenous malformations. And I would like to turn it over to you, sir, if you are ready.
Okay. Hello, everyone. I'm going to share my screen. It's a little difficult. Sorry for short delay. All right with you? The screen?
Yes.
Yeah. A little minute. Okay. Everything's all right?
Yes. Okay.
Very good. Hello, everyone. First, I would like to thank for the introduction, which was very exhaustive. Thanks to the organizers of the YNS seminar for inviting me, and many thanks to Professor Yoko Kato, who definitely is the driving force of many, many activities throughout the world, especially in the Asian part, where obviously it's a majority of neurosurgeons there. Today I'm going to talk about the AVMs. The part one will be for young people, about how I do it. I will show you a few tricks and tips how to deal with the AVM. And the other part will be about the departmental series and meta-analysis, just to get to some conclusions about how to deal with AVMs today. I do not have anything to declare. I have listed here 20 points which are surgically important and which I am really going through nearly like a pilot's list before any surgery for AVM, because there is nothing like easy AVM surgery. But the time will allow me to show you only a few of them. So I will show you those which I really feel are important. First, of course, is planning the approach. That's the important part before surgery. You would like to position the patient in a way that you will have your nidus on the surface, that you will approach the AVM along the long axis of the nidus, and that the approach will be vertical, because it will be comfortable for a surgeon, it will be comfortable for everyone, because it will be like in any other surgery. I'd like to demonstrate this on this case of grade 1 AVM in frontal region, which is on the left, dominant side. And from whatever direction you would come on the left, you would have to retract the brain, and you would have the nidus a little bit behind the corner. The other obvious approach is from the contralateral side, cutting the falx, reflecting the falx, and then you really have your AVM in a direct vision. Your approach is really vertical. You are coming along the long axis of the nidus, and more to that, all the feeders are first seen because they are coming from anterior cerebral artery. So first you easily deal with the feeders and then with the nidus itself in a very straightforward and very comfortable way. Okay, this is the NGO. After the surgery, you see a little aneurysm on the pericallosal artery. This disappeared within a year. That didn't need any treatment. Exactly the same case in the occipital region, again coming through the falx directly to the AVM with no need for retraction, no need to go via any cerebrotomy, whatever. Very comfortable. The next point I would like to point out is that this is AVM surgery is not for minimally invasive approaches. You need a large enough craniotomy which would extend well beyond the nidus margin, so that you can get good orientation about the feeders, about the draining veins, about the position of the nidus. You wouldn't like to go behind the corner or underneath the bone. Open dura carefully. That's not mentioned quite frequently, but this is extremely important, since there are very frequent adhesions between the nidus and the dura. And most frequently you see these adhesions between the vein, the draining vein, and the dura. So should you tear it and should you reflect the dura as in a usual manner, you may be done with your AVM surgery very, very early on, at a very early phase. Let me show you the example, what it looks like. Okay. You see the dura, you see the AVM now reflecting the dura. You see all these adhesions between the nidus and between the AVM, and there are vessels which are extremely fragile. As any vessel in the AVM, those are not fully developed vessels. Those are really pathological vessels which really have a great propensity for rupture. And should you tear it now, should you do some, let's say, too aggressive movement, then you have the bleeding, like in this case. This was fortunately easy to manage. Here's another case like that, and you see that the adhesion is directly between the vein on the surface of the nidus and between the dura. So this is something which really needs to be taken care of, and which is rather dangerous for any surgery. Then coming underneath the dura, the important point is to dissect the margins of the AVM, and it's arachnoid sulcal dissection. This is the beautiful part of surgery of the AVM, because it's very clean. It's usually without any difficulty, which comes only later when you get deeper into the AVM. This is the left temporal AVM. You see that the draining vein is circumscribing the nidus, and this is what it looks like at the beginning. So here we have the Sylvian fissure, which is delineated by the large draining vein, and sharply cutting. The most important instrument in AVM surgery are good scissors. You are just reflecting the vessels of the AVM downwards towards the base of the temporal lobe, and you slowly are exposing the superior temporal gyrus, which actually is not involved in the AVM, which is just covered by the vessels. You see this large vessel here, the artery. You may consider this vessel to be the main feeder of the AVM, which it is not. Do not cut it, because you are in the Sylvian fissure and you really do not know what it's about. Let's go further. So you will want to dissect en passage vessel. This is probably the most important message of this part of the lecture, that all vessels should be considered as en passage unless proven otherwise. Patient coagulation of the vessel, of larger vessels especially, and cut the coagulated vessel stepwise. By first cut, just open the lumen, but keep the vessel in continuity. Unless you do this and the vessel bleeds, it may retract into the brain and you will be chasing the bleeding vessels everywhere. On the other hand, if you cut it stepwise and it still bleeds, you can easily coagulate it. So here it is, and you see that tiny artery on the surface of the nidus, and this tiny artery doesn't belong to the AVM. It's not the AVM vessel. This is the AVM of this is the vessel of the superior temporal gyrus. So you may dissect it free from the nidus and keep it patent, which is not really important, but it's good not to sacrifice any vessel which you meet throughout the surgery unless it is part of the AVM. Here you see the bridging vein between the drainer of the nidus and between the main draining vein in a Sylvian fissure, so you may easily sacrifice it. And you see how patiently and for a long time am I coagulating this vessel before cutting it stepwise. And this really is important, because you keep your bleeding points or your bleeding possibilities restricted to one single spot, which you may be able to deal with easily. And now just opening the lumen, it doesn't bleed, okay, you can continue with the section. The next important point is to identify any bleeding point properly, and especially deal with this bleeding point properly. Don't just do something like a half measure, just control the bleeding by some tamponade or something like that and go ahead. These bleeding points, they have in AVM the tendency to multiply, and suddenly you are in a pool of blood with many bleeding sources, and you may be unable to deal with it. So go one by one. Once you have some bleeding, just deal with it properly and permanently. Here the draining vein is bleeding. You see that the bleeding is rather severe. I wouldn't go forward unless I would deal with this bleeding properly and permanently. In this case, it was a wall clip on the draining vein, and only after this I'm going to continue. I wouldn't use any cotton pad or something to use it. Now you see the vessel underneath the nidus, and as you are slowly dissecting this vessel, suddenly it appears that was the vessel from the origin of the video, from the first video, and you see that actually this is not the AVM feeder, this is the regular branch of the middle cerebral artery. And since we are working on a dominant side, it definitely is important to preserve this vessel properly. So let's go forward. Okay, this is after surgery. Once again, please let me talk about these en passage vessels, just to make sure that I got the message across. You see the vessel on the right, the artery. It definitely looks like feeding vessel of the nidus, which is here. But as you dissect the further, suddenly it appears that we are dealing with something else. Lifting the nidus a bit, you see a large vessel just in the axilla of this artery, and this is the true feeder of the AVM which you need to deal with. I can jump one video. It's here now, you can coagulate it or clip it, whatever your preferences. And this is at the end of surgery. The AVM is resected, and you see that the artery, which looked like the feeder, definitely has nothing in common with the AVM. Both branches are feeding the normal brain, and these are not the small branches, so you would like to preserve them. So all the time, any artery must be considered as en passage. The difficult part of AVM surgery is the depths in the white matter with deep feeders, where there are these pile ependymal feeding arteries, there are tortuous, they are really pathological, and they are almost impossible to coagulate. So what I'm doing, they look like this, they really look a little tortuous, and you may coagulate them, they reopen, you coagulate, they reopen. I don't like the dirty coagulation Ernest is talking about, because then you really sacrifice the brain in the vicinity. So what's best is use mini clips, and we now have those tiny AVM dedicated mini clips which doesn't hinder your approach. So you may put several of them, you may remove them at the end, but I usually leave them behind, and that's the best how to deal with all these tiny feeders, and how to prevent bleeding, which is extremely difficult to control. So clip, coagulate, cut, clip, coagulate, cut, all the time the same, and you may end up with several clips in the surgical field, but it really doesn't matter as long as you really have your vessels under control. The next important point that you should have all important structures under direct visual control at all times throughout the surgery, not to harm anything. This is the CP angle AVM. You see the 5th nerve, you see the 7th, 8th nerve, and all the feeding arteries and draining veins were running around these nerves. So you need to keep under your control all the time both these nerves while resecting the AVM, the nidus of which is just in the flocculus area. That's after surgery. The approach along the vein, you probably have read it in the literature. Sometimes it's extremely rare and rather difficult. This is a tiny AVM in the quadrigeminal plate in the superior colliculus area. You see it here. This is the direct injection. The endovascular people refuse to embolize it. I don't like much radiosurgical maneuvers in and around the brainstem. So we took the patient to the OR, and you have no way to distinguish what is the feeding artery and what's not. This is the suprainfracerebral cerebral approach, and you see the atypical vein on the ICG, and then you go along the vein, slowly cutting all the vessels entering this vein. That's the only way how to coagulate some of these vessels, all of which may be the regular arteries feeding the quadrigeminal plate and the surroundings. So this is not really that easy, but in such a case, it's the only way. This is at the end of surgery. Here you see the bed of the AVM, and here is the stump of the atypical or pathological draining vein coming up into the vein of Galen area. This is after surgery. The very logical step is, of course, to preserve the vein until the very end. In this case, I made a mistake, and I will show you what happened. This is a draining vein, which is very narrow, entering the sinus directly posterior to the AVM. Everything went very straightforward, very easily. I use retectors only when I need them. I'm not really against them, but when you do not need to put them in, you do not put them in. In this case, I became reckless and somewhat lazy at the mid of the surgery, and I wanted to retract the posterior temporal lobe a bit, you see the bleeding started. It was really not difficult to control this bleeding from the only draining vein, and this is what ensued. The prolapsing brain, bleeding AVM, really dramatic situation for a while. Fortunately, this was the right temporal lobe, and you could have enlarged your approach. Let's see what was the final result. The patient is fortunately doing well. I'm not jumping from one slide to the other again. Yes, that's after, and you see that the extent of resection is somewhat larger than intended before surgery. What about the combination of treatment? It means pre-op embolization. I really do not like it, and we use it very seldom. As a solo treatment, we do not use embolization anymore. We use it as a pre-surgical adjunct only, and only very, very rarely, because I don't feel it really helps. However, this male probably was the only way how to deal with the AVM. He was deteriorating, so we embolized the guy, and we embolized him over the 10 years period several times, I guess 7 times, and that remaining AVM within the cerebellum. And that was the point when we got to surgery. And you will see that it was not really an easy surgery. It was rather difficult to get some orientation. It was rather difficult to move the firm tissue and glue all the vessels which were previously embolized. When you opened them, they bled nicely. So it was rather difficult. I do not think I would be able to deal with this AVM without the embolization, but to deal with this AVM even after embolization, you see how it's bleeding everywhere. It was by all means not easy, and nearly totally embolized AVM is still bleeding like hell, and it's still nothing very elegant surgically. Fortunately, we got by with that. The patient is doing well with some remaining cerebral symptomatology which he had since the first time we have seen him. This is after. Even the images are difficult to interpret. All the AVM surgery, whenever possible, should be in a cold stage as an elective. Even if it bleeds, you would like to decompress the brain only, should you need to do so. And there are only rare exceptions when you will deal with the AVM at the first stage during the emergency or during acute surgery. This one was very easy to find. This one was very easy to localize even on CT angio, and this one was in the frontal area, so no problem in that. But never ever when you get into the fresh AVM, you get a good orientation, because everything's obscured by blood, and you do not know what is the feeder, what is the draining vein, where the nidus really is. So the extent of resection always is much larger than needed. And this is after the surgery, the patient did well. Concerning the ICG, we are using it in all AVMs, but apart from the information about the direction of the flow, I didn't find any real profit, unlike with aneurysms or anything else. So it's nice to have these images, but really the profit from these images is not that big. So 20 points again, and we are going to the next part, which is clinical and meta-analysis. Mr. Chairman, how much time do I have?
You may continue, Professor.
Okay, so this is our series of 320 AVMs, and you see that we are using all 4 legitimate treatment modalities: surgery, endovascular, radiosurgery, and observation. Obviously, in the surgical part, the majority of patients were in grade 1 and 2, and the same was true for patients in observation group, which is just a little paradoxical. What's always needed to be evaluated is the efficiency, it means complete eradication of AVM, because as long as there is one little shunt left behind, it's exactly the same as if you would have done nothing for the AVM. So the efficiency of the cell treatment modality, and surgical morbidity mortality, because you are trying to beat the natural course. So in surgical group of 140 cases, we have had efficiency 97% and surgical morbidity mortality 3.4. Of course, there were other patients who died, 4 of them, who died or were severely disabled due to initial bleeding. Then the endovascular group, it's smaller since we are not using it as a solo treatment or primary treatment anymore. The morbidity mortality was 8.5%, which is exactly in accordance with meta-analysis I will show you shortly. The efficiency was rather high, probably surprisingly high. We are using Onyx, so it was 37%, which is really on the scope of the high efficiency, and we probably were just lucky. See, in this comparison between the endovascular and surgical group, the surgery for Spätzle-Martin group 1 and 2, it's 100% efficiency and 0% morbidity mortality. Nearly over 20 years of surgery. So this is definitely the best group of patients. The surgeries are not that difficult, but still be taken seriously. And the results are extraordinary, exceedingly good. All our troubles appeared with Spätzle-Martin 3 and 4, where our morbidity mortality in surgery was 28%, which in a way, compared to natural course, is unacceptable. What about the radiosurgical group? There were 61 patients which we have sent to radiosurgery in gamma knife. In our case, 2 patients died and bled and died in the latency period, and the obliteration rate was 58% in 26 patients out of 45 who have finished their 3 years period time. Observation, surprisingly, there was 1 case of spontaneous thrombosis, given the efficiency of 2%, and 3 patients who bled and died, giving morbidity mortality 5.5%. This was in 54 patients. So these are our results with all 4 treatment modalities. Altogether, these 320 patients, we were able to deal with properly and totally with AVM is 74% of patients. It means 3/4. The rest were impossible to treat. Then the morbidity and mortality was 4.1% procedural, but altogether it was 11.1%. The difference between was caused by the initial bleeding. So actually this is rather optimistic for such a difficult disease. And this is the meta-analysis. This is the surgical effectivity. You see that it exceeds 95%, which is obvious because you cannot run away from the AVM. You really must deal with that on your surgical table. So efficiency is very high. The morbidity mortality, again, is very coherent all throughout the series, and it ends at 7% morbidity mortality, considering all Spätzle-Martin grades. What about the efficiency of endovascular treatment? It's a bit more scattered, but still it gives nothing better but some 20-25% efficiency. Even with Onyx, this doesn't get much higher and nowhere close to 50-60%. Endovascular effectivity with Onyx only, you see it's higher, but definitely not that higher. Complication rate, again, is exactly the same as in surgical group, some 7% morbidity mortality caused by the treatment. Radiosurgical meta-analysis, surprisingly, the efficiency is rather scattered, coming from 30% up to 92%, but overall, it's something above 60%, 62-64% efficiency of radiosurgical treatment, it means the AVM is completely occluded. The risk rate of, let's go backwards a bit. This is the complication rate of radiosurgical treatment. Again, it's 7%, so exactly the same as with endovascular and as with surgical. Complications in radiosurgical group are later on. There is some 6 months delay, and all the troubles appear, if they appear, some 6-7 months after the radiation. This is some novel technique which we are not using. This is a patient which we subjects did to observation. She then went to US, and in Denver she was treated by some fractionated radiosurgical means, and you see that the effect is excellent as long as we shall perform angio in a month or two. So this is what's probably an important slide of my presentation. The annual rupture rate is 2.2%. These are the figures from Aruba, and these are the figures from previous Montreal group publications. The risk of bleeding from the AVM is not as severe as the risk from bleeding from aneurysm, and it gives morbidity mortality rate of 30%. So these are the figures which should be taken into account at the very beginning, because AVM surgery is a preventive surgery. You want to prevent the bleeding, just let's say excluding the risk of any bleeds. On this graph, on the horizontal axis are the years. We see majority of our patients in their 30s. It means that they have some 40 years to live, which you need to consider. And on the vertical axis, there is the probability of poor outcome given these figures, 2.2 and 30%. The blue line is the natural course. And you see that in 40 years' time, the patient is really exposed to the risk of some 24-25% that his AVM will either kill him or disable him permanently, which is not really that a pessimistic outlook. The green bar is the endovascular treatment. Given the effectivity of 30%, given the complication rate of 7% at the beginning, you see that the graphs are starting earlier. Over the 40 years, the endovascular treatment doesn't give any profit to the patient, because the results are exactly the same. With the low effectivity, the patients are still exposed to the same risk even after 40 years. Radiosurgery is much more optimistic, twice better than the endovascular. You give some profit to your patients in 20 years' time. After 20 years, they are going to profit from radiosurgical treatment given the 60% effectivity. So there is no point in irradiating a patient who is 70, who is 60. It's you hardly can beat natural course at all. This is not the case for surgery. In surgery with 7% morbidity mortality, considering all Spectrum-Martin groups, you give some profit to your patient in 10 years' time. So even older patients like 50-ish, early 60s should and could be treated by surgical means, because the effectivity is 100%, and again, the risk rate is 7%. Considering only grade 1 and 2 AVMs, which have nearly zero morbidity mortality, your patient will profit from your surgery almost immediately, within a year, and you already beat the natural course within a year. So this is a good graph to explain to the patient what you would want to offer him, and this is a good graph to explain the patient. What about Aruba? Only one slide about it. That the study virtually compared endo and radiosurgery versus observation over a very, very limited time, over 3 years. It's in the life of AVM, it's nothing. And the conclusion, the only conclusion from Aruba for me, that unruptured AVMs, Spectromartin 1 and 2, should not be treated endovascularly or by radiosurgical means, because you may remember the results. There were only 5 surgical cases in the whole Aruba study. And the next conclusion, of course, given the good results, is that AVM, Spectromartin 1 and 2, is a surgical disease with no matter to presentation, nearly with no matter to the age of the patient. It's always something which should be done. So good surgery is superior to radio surgery, and it's superior to endovascular and natural course. Bad surgery, of course, is inferior to anything. What one needs is the competence, skills, experience, self-assessment. One must be honest to himself. Can I do the AVM? And am I able to resect it safely? The next important factor is honest information of the patient. And the choice should be done by the patient. If the patient comes to an institution which is good in endovascular treatment, he will be explained that everything can be done by endovascular means, and he's not even in some places informed about surgical possibilities or about radiosurgery. So the patient should be fully and really honestly informed, and she should decide. This high volume and well-equipped center for AVMs, it's not easy. There are not many of these places like that. The AVMs everywhere are seldom surgeries. There are really very few patients who are operating on AVMs on a weekly basis. It's very, very seldom. So that would be the logical requirement for AVM surgery, which is almost impossible to fulfill. So just to conclude very easily and very straightforwardly, and there's nothing new to this because everywhere this was said several times, that Spectromartin 1-2, it's a surgical disease. Spectromartin 3, very heterogeneous group, which means very heterogeneous treatment approaches, and each patient should and must be evaluated individually. And Spectromartin 4 and 5, the observation is treatment of choice, since any active measure is more dangerous than the natural course, with some 20% morbidity, mortality, it's obvious. The only time when we go for grade 4 and 5 patient is when we are facing repeated bleedings from the AVM. This is my philosophy. Whenever possible, use monotherapy. If you will use 3 endovascular sessions before surgery, just pre-surgical adjunct, and 1 surgery, these are 4 active measures, and given 7% morbidity mortality rate of all techniques, you are exposing the patient to nearly 30% risks, which is not really something which should, and even I would say can be done. It's too high, simply too high, and simply you never ever could beat the natural course. Over the time, I have had 4 patients whom I treated surgically after the failed gamma knife surgery. These 4 AVMs were the easiest which I have done. It was really very straightforward, very easy, no bleeding, no dangers, very easy to exclude the AVM. The only trouble was to find it, of course, but we have navigation systems. And this is the treatment protocol which never was studied in a systematic way. And I believe that this is really our mistake, that we do not study these patients who were treated by radiosurgery. Then there are 40% of them in whom the AVM is not really excluded, and this must be treated by some other means. Then surgery is really the treatment of choice, and this is something we didn't study systematically. So this is something we probably all failed to do, and we should do in the future. Should you want to learn more about the AVMs, get this book, because there are by very respected authors all the details, all the surgical tricks, all the natural course data, all treatment modalities, everything's covered there. And that's all for today. I thank you for your attention, and I really enjoyed my being there with you.
Thank you very much, Professor, for a very nice presentation and a lot of conclusive statement given by you in AVM treatment. I think Professor, will you be staying on? Professor Ben, will you be staying on?
Yeah, I will.
Yeah. So we proceed with the next presenter first. Dr. Ahmad Fahmi, could you please introduce our next speaker?
Okay, thank you very much, Dr. Liu. And the next honorable speaker will be Professor Kojiro Wada. Now he is the chair professor of Department of Neurosurgery, National Defense Medical College, Saitama, Japan. And he has many professional affiliations, including Japan Neurosurgical Society, Japanese Congress of Neurological Surgeons, Japan Association for Cerebral Blood Flow and Metabolism, and the Japanese Society for Hyperbaric and Undersea Medicine. And his research and surgical interests are pathophysiology of carotid atherosclerosis, hypothermic therapy on brain ischemia and traumatic brain injury, ischemic preconditioning, carotid and aortorectomy, and surgery for cerebrovascular disease, including various vascular bypass, and skull-base surgery and hyperbaric therapy. Please, Professor Kojiro Wada, you can present your presentation. Thank you very much.
Thank you very much. I would like to thank you, moderator, and Dr. Yoko Kato for giving me such a great opportunity today. So, the Olympic Games are coming to an end in Japan. I don't know if my talk will be something to get excited about, but I hope it will be of some help to you. Now I'll begin my lecture. I'm talking about carotid endarterectomy hands-on using CES simulator. Can you hear? In this slide, I show the instruments for carotid endarterectomy. Number 1 is scalpel, number 11. Number 2 is needle holder. Number 3 is the bulky vascular tissue forceps. Number 4 are bulldog forceps. Number 5 is Potts-Smith dissecting scissors. Number 6 is dissector for plug. Number 7 are straight mosquito forceps. Number 8 is 3-0 nylon. Number 9 are vascular tape, blue and yellow. Number 10 is CV5 Gotex suture for primary suture for carotid artery. Before using internal shunt tube, preparation of internal shunt tube is necessary. Prepare 2 plastic syringes of 2.5 cc. Replace the air in the balloon of the tube with saline solution using the syringes. Inflate the balloon with the saline solution and make sure it has a nice spherical shape. The other side of the balloon is also replace the saline solution and inflate with saline and make sure It has a nice spherical shape of balloon. Deflate the balloon. Fill the tube with heparinized saline. And clamp the blue shunt tube on the common carotid artery side with a straight mosquito forceps. Two 2.5 cc syringes with saline solution with 1 cc. I will show the video. Use a skin marker pen to draw the planned incision line. The water flow is blocked with a bulldog forceps on the left side as the internal carotid artery, then blocked on the right side as the common carotid artery. Pinch the blood vessel on the right side with your fingers and make an incision of about 1 centimeter with a scalpel. Potts-Smith dissecting scissors is used to cut along the planned incision line. Tourniquet is made using a Nelaton catheter. Cut the Nelaton catheter into 3 cm pieces and the 3/0 nylon thread is inserted into the Nelaton catheter. Wrap the blue vascular tape and thread the end of vascular tape into Nelaton catheter. Yellow vascular tape of another side also wrap and thread into Nelaton catheter. One side of fully internal shunt tube is inserted into the internal carotid artery. Balloon is inflated with 0.3 cc saline. Then tie on the tourniquet. Flush the inside of the shunt tube with heparinized saline. Left side internal shunt tube is clamped with straight mosquito forceps and right side is declamped. Another side of internal shunt tube is inserted into the common carotid artery. Balloon is inflated with 0.5 cc saline. The tourniquet is tightened. Flush the inside of the shunt tube with heparinized saline. The insertion of the internal shunt tube is performed by two people. One person inserts the shunt tube and the other person operates the balloon and flush of the internal shunt tube. Once the shunt tube is released, the internal shunt tube is complete. The blood flow right to left. The shunt tube forms a loop. Change this loop to an omega shape. This will make it easier to dissect plaque in the periphery. Plaque dissection is started from the left end of the internal carotid artery side. Once the plaque has been peeled off, proceed with the peeling toward the right. The end of plaque of common carotid artery side is dissected and cut with scissors. Opposite side of plaque is dissected. Finally, the plaque is taken off. The internal shunt tube, now in the shape of an omega, is rotated to return it to its original loop. Divide the CV5 Gore-Tex suture of the double-ended needle into 3 equal pieces and cut them into 30 cm lengths. Primary suture is performed using this CV5 Gore-Tex suture. The first stitch of the suture is started at the left end, where there is no incision. Tie a knot 5 times. Continuous sutures are used and no interlocking is done. After suturing to the right side of the middle, the procedure is stopped. Next, for the right end common carotid artery, the first stitch is done in the same way, starting from the right end incised area. Tie a knot 5 times. Continuous suture is then proceed. The suture is finished. The internal shunt tube is removed. Yellow shunt tube is clamped, and the balloon is deflated. Internal carotid artery shunt tube is removed. Internal carotid artery is clamped with bulldog forceps. Blue shunt tube is clamped. The yellow shunt tube is declamped. Yellow balloon is deflated, and the common carotid artery shunt tube is removed. Common carotid artery is clamped with bulldog forceps. Continuous suture is restarted. When you done the suture, turn back. And the two threads tie a knot 5 times. The two threads is cut. The bulldog forceps are released. You can confirm the water stream without no water leakage. The procedures of the clamp are: first, superior thyroid artery; next, external carotid artery; third, internal carotid artery; and finally, common carotid artery. Thank you very much for your attention. Let's do carotid endarterectomy. Thank you very much.
Thank you very much, Professor. It's a great lecture. Thank you very much. Okay, we discuss now about our.
Yeah, I think we open for
the last
questions.
session,
Yeah, we can open for questions before we go to the YNS speaker. Any question from the floor or from the panelists? Yes,
I have one question. My question is for Dr. Amit, Professor. Thank you for the talk and about development of neurovascular system. And I have a question about middle meningeal artery supplying choroidal through ophthalmic artery. Like if when coagulation of middle meningeal artery, can it result into blindness if the scenario is with supply of middle meningeal arteries to the choroidal vessels?
Okay, thank you very, very much for that. Now, in simple cases like just an extradural hematoma, you have situations where you have maybe a sort of a temporal extradural hematoma. You're trying to take it out. There's bleeding that's coming down, often from foramen spinosum area. Now that's quite low. Now, as I had showed you in the angiograms of those children, you can have the anterior branch of that middle meningeal artery being now the sole supplier to the eye. So in a situation like that, if you do end up taking the branch very low down and actually taking that anterior branch of the middle meningeal, that can cause blindness. Now, in cases where one wants to, say, embolize a tumor, okay, it's important to make sure that you don't have any reflux going through any sort of variant vessel from that middle meningeal through to the ophthalmic system, because in a single 100 micron particle going down the retinal artery is equal to blindness. So the answer to your question is yes. If there is this important little connection that we had seen and one is not cognizant of that fact, then you can either damage the middle meningeal unknowingly and cause blindness, or even just embolizing with particles can actually cause blindness. So the answer is yes.
Thank you, Professor. So we need to be careful whenever we are coagulating middle meningeal artery. It's not easy and deep coagulation. It should be whatever is needed and above coagulation.
Yeah, so the point of coagulation is also a very important factor. So it's just actually be wary that if you are going to coagulate the anterior branch, there can be that link going through to the ophthalmic system. Yeah.
Thank you, Professor.
Thanks a lot.
Any other questions?
I had a question for Dr. Benes. When an AVM comes in that's ruptured, how do you decide at what point to intervene? Do you typically intervene early, or do you wait for the hematoma to resolve?
I didn't catch the first part of the question.
With a ruptured AVM, how do you determine when to time your intervention?
That's a good question and a difficult one. There are cases where we really resect the AVM on the same day, the case I have shown. If it's easy, very well delineated, you see the nidus on your CT angio, and the hematoma is really causing a severe mass effect. But those are very seldom. Then there are cases where we only resect the hematoma, not the hematoma which is directly adjacent to the nidus. This part we leave behind, and we come in a cold state or in an elective manner. And in a regularly ruptured AVM, where you do not need to do anything at the beginning, we usually wait something like 3-4 weeks just to get the hematoma liquefied, because hematoma usually does half of the work for you. So why don't take advantage of that, having liquefied hematoma? So 3-4 weeks is the usual time.
So Benes, thank you very much for a nice lecture. Just I want to know if the compact nidus, the AVM, easy to recognize of the dissecting plane, but sometimes it's very difficult to where is the dissecting plane, such as the nidus is not in the sulcus, but also in the parenchyma itself.
Yeah, Yoko, this is something which is extremely difficult. Those diffuse niduses, the scattered ones, you know, where you have the feeling that there is the brain in between the parts of the AVM. Unless necessary, we try to subject them for observation, and we do not operate on them. The compact nidus, it's very straightforward. You go along the margin of the nidus, you see the vessels, and you know where you are, and you can measure the nidus to know how deep you need to go, all these things. But if it's a diffuse thing, it's extremely difficult. And then the resection functionally permitted is a little larger. Then we go through the brain, through the adjacent brain, if it is not eloquent.
Okay, so one more thing is some textbooks said that after radio surgery, the surgery is the direct surgery is easier. How do you think about that? Or some mechanism, or
it's there's the experience of 4 cases only, Yoko, not more. I have seen only 4, but always the tissue was rather firm. To find the vessels with navigation was very easier. The nidus was much smaller and much firmer, and also the vessels were much easier to coagulate, because there were these neoplastic changes caused by irradiation. So there was really vessel wall which you could coagulate. So all these factors taken together were easier than with regular AVM. The only thing was to find the AVM. All these 4 cases we did in the intra-op MR setting. Should I miss the AVM, I could go for intra-op MR and find it again. So that was the only difficult point. Otherwise, really, the vessels were much easier to coagulate, very easy to dissect from the surrounding brain, and more to that, the brain was actually irradiated and dead in the vicinity. So these were the factors which were really favorable for surgery. Much smaller nidus, better vessels, and gliotic tissue around the AVM.
Thanks so much. So my question to the Dr. Amil, thank you very much for a nice presentation. So how much percentage the ophthalmic artery comes from the extradural, and also to know such a anatomy, how you can useful for the clinical, daily clinical the treatments.
So for the first part of that question, and I'm not sure, but what I have seen is that there seems to be higher percentages of the external carotid being a supplier to the eye in small children. The sort of DSAs that I've been involved with children that have come in for retinoblastoma, for example, and up to 20 to 25% of children lesser than 4 years old will have external carotid supply to their eyes. But I don't see the same pattern in adults. I mean, we certainly do a lot more digital subtraction angiograms in adults than in children, and I don't see the same high numbers. I don't know if there's a change that happens when these children are maturing, or whether the ophthalmic system is still actually maturing in these smaller children to now start taking over that middle meningeal supply. But certainly in children, there are higher sort of incidences of external carotid supply to the eye.
So much. Thank you.
Thank you.
Amir, how would you explain hi, Amir. How are you?
I'm well.
How would you explain the external carotid supply to the regular AVM in the brain? You have the supply from middle cerebral, anterior cerebral, and then there is additional supply from external carotid. I don't understand it developmentally.
Okay, so from a developmental standpoint, we know that, like I had mentioned, that stapedial artery is actually a branch of the internal carotid that will regress in most people. But in that regression, there are branches that still go and supply the dura, like I had shown. Now, we have seen that there are AVMs that when one goes to do a DSA on, they do get meningeal supply coming through to them. Now, in those AVMs, then it's often the middle meningeal branch. Like I had mentioned, that mandibular maxillary branch that changes its name to the middle meningeal that now gives that supply. Whether these AVMs, because of vasculogenesis, take over that meningeal supply, and with time, that meningeal supply becomes a more and more dominant supply, which I think is what happens. But yes, there are AVMs that do then get supplied from the middle meningeal, and often will, I mean, I certainly don't operate on as many AVMs as I've seen being embolized, but those AVMs, you do need to embolize through the middle meningeal, and just make sure that that middle meningeal and whatever you're supplying does not have supply through to the skin, because the last thing you want is to embolize it and then now you get a necrotic patch on the skin. But yes, and AVMs can get a supply from the middle meningeal.
Can I ask Dr. Wada? Dr. Wada?
Yes.
Just you can tell us that you use the shunting system during your CEA. So what is the condition of do you use some monitor? So when is the shunt is needed? Just you can tell us, or we need every case or not? Please tell us.
Thank you very much. The question. Usually I use this internal shunt tube every time, but the selective shunt tube is reported. So for the selective shunt tube use for the patient, so the stamp pressure under the 40 millimeter mercury, or the we usually use the monitor of the SEP and the somatosensory evoked potential, that means. And also I use the inbox regional oxygen consumption. In the SCP, gained 50%. It is the condition to use the internal shunt tube. And also the inverse, the first I get the number of the inverse and the 20% of the decrease, that means necessary for the internal shunt tube, I guess. Thank you.
Okay, thanks so much.
Can I, Yoko?
Yes, please.
I congratulate you on doing carotids. This is not the case anymore in Europe. There are very few departments dealing with carotids. It's done by vascular people, whatever. We are losing it as neurosurgeons, which is a pity. Actually, we are monitoring all the patients. We are doing like 100 surgeries a year, a series of more than 2,000 cases. We are using SEPs, somatosensory evoked potentials, for monitoring, and our rate of shunts is below 2%. Less than 2% of patients do need shunt. And shunt, whatever you call it, whatever you do, is another risk factor in surgery. So if you can avoid it, it's always better to avoid it. We do not avoid it always, but a regular need or a real need, in my mind, is really less than 2%, giving you the overall morbidity mortality rate in enterotracheotomy something like 1%, 1.1%, which is more than acceptable considering the previous studies. And then I have one tiny technical remark. Distal tourniquet is taking space. Especially in high-positioned bifurcation, you may end up with limited space for tourniquet. We are not using tourniquet anymore. We are using very simple window aneurysm clips. There are different sizes, and you just put it across the shunt, and it's easy, not keeping any of your space.
Swara?
Thank you
Yes.
very much for your comment. Yeah, that's true. And in this video, I used the tourniquet, but in real operation, of course, Venice mentioned already, the distal space is limited. So I also used a link clip. Link clip means Sugita link clip for the secure the distal shunt tube.
Right.
Thank you very much.
Thank you. Thank you. Great that you are doing carotids. I love it.
So in Europe, almost 100% of the casts finished.
Yes?
In Europe, the no more CA and almost 100% of the casts stenting.
No, less than 2%. Less than 2%. 1 or 2 out of 100 patients do need shunt. You know, we dissect the bifurcation, then we occlude the internal carotid artery, and for 1 minute, the evoked potentials are monitored and we are waiting. If they do not deteriorate, then we go ahead with surgery without any shunt. If they deteriorate, we increase the blood pressure of the patient. In many instances, the SEPs improve and we can do without shunt anyway. Only should they really fall for, let's say, permanently, then we use the shunt. And the clinical results are the same. I had a time in late 80s when I was using shunt in all cases. That's not really necessary. And now we are really down to 2% and less, 2% shunts.
Thanks a lot.
I have one question from Professor Kojiro Wada. Professor, yes. Thank you for the lecture. It was a very nice lecture, and I'm planning to do carotid endarterectomy next week. So my question was, during declamping of the clips, you said first declamp superior thyroid artery, then external carotid artery, then internal carotid artery, and then common carotid artery. So, shouldn't we declamp the internal carotid artery in the last stage to avoid migration of any fat emboli or thrombus into brain?
So thank you very much. That's a good question. The first, I released the superior thyroid artery, so that to feel from the diffracts from the superior thyroid artery to the blood vessel to filled inside the carotid artery, all carotid artery. That makes sure the leakage from the suture first, and maybe a small leakage. After that, I release the external carotid artery. So more blood refracts from the external carotid artery and filled inside. And then I usually release the internal carotid artery. Usually the internal carotid artery is more flow than the external carotid artery. So the maybe a small plaque inside the blood vessel go through to the superior thyroid artery. So the small plaque flush to the superior thyroid artery, I think, and then the common carotid artery release. If you are very worried about the inside the plaque, maybe not so worry about that, but before release the common carotid artery, once again the close the internal carotid artery you mentioned, and release the common carotid artery and flush the external carotid artery. Then release the internal carotid artery. That's a good idea, I think. And each step, I use the 10 seconds. Each step, 10 seconds. Yeah, that's all. Thank you very much.
Can I add something to enterectomies, Dr. Wada?
Yes.
Yeah.
Yes,
We are using different sequence. First, we reopen the internal carotid just for a flash. You know, open close to flush everything from the internal carotid artery. Then we open the external carotid artery. Next is common carotid artery. And last is the internal carotid artery. It probably makes the same job as in your case. But I would like to have one more technical remark. We are using double suture. Many years ago, happened to me that the patient, after the surgery, when the wound was closed, suddenly his neck got swollen and he was deteriorating rapidly. I reopened the wound and the stitch, the suture was broken. Carotid artery completely opened. So since that time, we are using one suture, as you do in your beautiful model, and then another one very loose, which just keeps the first suture line secure, just to make sure that these sutures will not rupture. It's just for my security.
Thank you. Thank you for your comment.
A question from Prof. Mahmood. Professor?
Thank you very much. Nice to see you, Vlad and Yoko.
Hi, how are you?
Seeing you. And thank you for having me as a panelist. Some very basic questions regarding the carotid endarterectomy. How often, in terms of percentage, do you do, either Professor Wada or Vladimir, how often would you do them under local anesthetic? And I would assume that in all instances, you use the microscope.
Thank you. Thank you very much for your question. Compared to the carotid artery stenting, the difference between the CEA and the CAS, carotid artery stenting, is local anesthesia or general anesthesia. If we can do the local anesthesia, there is less risk compared to the maybe the carotid artery stenting. But I don't think that that's a good idea for use the local anesthesia for the carotid endarterectomy. I think I usually use the general anesthesia, not to the local anesthesia. I have no experience using the local anesthesia alone. And the next question is, excuse me, I couldn't. Microscope. Yes, I every time use the microscope for the endarterectomy every time. Yes, thank you. Thank you very
And
much.
Vlad?
Moody, I did my first in 1981, long time ago. Never ever did I do it without microscope or exoscope lately. Exoscope is excellent thing for that.
Yeah.
Gives you the same job as microscope, probably better. And we have tried local anesthesia once in more than 3,000 patients. There is a big randomized trial. I cannot remember the name, local and general anesthesia. There was no difference between the two. And it's always, in the only case I have used local anesthesia, the patient went hemiplegic and he was like moving on the table. So it was extremely difficult to continue. And we ended up intubating the patient and doing the general anesthesia. That was my only trial with local anesthesia. I know people do it. I know people love it. I know they have good results. But it's so comfortable to do endarterectomies under the general anesthesia that the patients who are not able to go for general anesthesia, in our case, are subjected to stenting. As easy as that.
And just one finally, we haven't done any in East Africa, but during the training with John Pickard, we would do them with a vascular surgeon, but we would then be using scintigraphy and cerebral blood flow evaluation rather than somatosensory evoked potentials. What's your take on that? Should we be relying more on radioisotope scintigraphy to check for blood flow changes during surgery, or somatosensory evoked potentials are sufficient?
Moody, you know, I'm old enough to live through all these monitoring techniques. The first was, and I guess Professor Vada has mentioned it, stump pressure, backflow. That was the first monitoring, completely useless. Then we went through things like compressed spectral EEG analysis. Then we went through the permanent ultrasound on the patient, whatever you name it. But for the past 10, 15 years, we ended up with these somatosensory evoked potentials, and we are very happy with them since it's very easy, very straightforward, and in our hands, very precise. I don't know, Professor Vada, what are you using?
Yeah, I agree. Yes, no.
I never tried scintigraphy, Moody.
Yeah, that's what we would be using to assess the cerebral blood flow at that time.
It's like ultrasound. I don't think, you know, to be trained by vascular surgeons in this field is a tragedy, because for vascular surgeon, it is the vessel he is operating on. We are operating it because of the brain. For vascular surgeon, it's even whether the vessel goes into the leg or into the lung or into the brain, wherever. It is the same, still the same vessel which needs to be treated. We are indicating our surgeries because of the brain. Our way of thinking is completely different. We have more symptomatic patients than asymptomatic. In vascular surgeon hands, it's completely opposite, with the same results, surprisingly. So I believe that this really belongs into the hands of neurosurgeons, and we should fight for it. Unfortunately, it's probably lost fight with endovascular techniques.
And if I may, just finally, what is the cutoff point on the stenotic region? Is it now 70%? Is it 40%? Because it moved from 50% with if somebody's had a stroke and it was 50%, you went ahead and offered carotid endarterectomy. And now it's like, if it's more than 70%, then you should consider endarterectomy. What's your philosophy on that?
Moody, I have a long lecture just about this, because this is the old American Heart Association recommendations are based on NASCET, ECSD, and these studies. And they say that symptomatic stenosis 50% and more, provided you have 6% mortality, is indicated for surgery. For asymptomatic arteries, it is 60%, provided you have 3% morbidity mortality. What we did was measuring the plaque. We were removing, like Professor Vada was showing, taking out the plaque. We were removing the plaque undamaged. Then we cut it on the histology, and all the diagnostic modalities, CTA, MRA, ultrasound, angiography, is underestimating the actual stenosis. So we had patients who had on angio stenosis of 50%, and on a specimen, on direct specimen, the stenosis was 70%. There is no correlation whatsoever. So what we should study is probably the length of the plaque and the texture of the plaque, whether it's fragile, whether it's hard. So these are probably more important parameters than the actual stenosis. What would you be doing with patient who has repeated transient attacks within a week and is having a stenosis of 40%? I would do endarterectomy. Professor Vada, what would you do?
The same
The same. You
criteria.
See, against all American Heart Association recommendations.
Great. Thank you very much. Thank you.
Professor Benes, just one quick question, if I may, based on your comment on using the exoscope for carotid endart. What are your thoughts on using the exoscope for surface AVM resection?
Sure. Exoscope is an excellent tool. You have a little brighter field of vision. You do not have the microscope in front of your head. And you can do anything in the same way as with the microscope. And you can teach people much better because they see it excellently. The only trouble I really found was supra-infracerebral approach and retrosec, because then your screen is a little to the side and you are not operating in your vision axis. With the microscope, you always have your hands in the axis of the microscope. So when I was doing petroclival meningioma with exoscope using supra-infra approach, I was having my hands like a little to the side. And the trouble was that the assistant always needed to push my hands into the wound. But otherwise, it's perfect. Excellent.
Thank you.
Thank you for the wonderful discussions. May I call upon Dr. Ishu to introduce our next two speakers?
Thank you, Dr. Liu. So now I will introduce our next speaker, Dr. Reddy Rahmani, and he is currently undergoing neurosurgery training at University of Rochester Strong Memorial Hospital at New York, USA, and he has published 25 papers, and he has presented oral presentations and posters more than 15 places, and he is having a pending patent for endovascular catheter, and he is a brilliant neurosurgery resident who is doing very good work, and he has also done few projects and about aneurysm, like vitamin D deficiency in aneurysm surgery, aneurysm rupture, and in various analysis of airway pressure release, ventilation in aneurysmal subarachnoid hemorrhage. And today he will speak about neurosurgery residency expectations, actual training, and experience gain. So I would like to welcome Dr. Reddy Rahmani to present his topic. Thank you.
Good morning, good afternoon, and good evening to everyone. Unfortunately, I don't think my presentation will be as informative as the previous, but Dr. Sachin asked me to talk about my experience with neurosurgery training. Everyone can see this okay and hear me okay?
Yes.
All right. So just briefly before I go further, just some disclosures regarding a couple of the things that I'll talk about. Medtronic and Hemionetics have given us educational and material support. So my story, I was born in Albania in 1990, and Albania was unfortunately fell behind a bit under dictatorial rule. And in 1990, the collapse of the dictatorial government really opened up the country. And in just the 30 years that I've been alive, it's undergone significant change. As you can see here, this is the old Tirana, which is the capital, and what it looks like now. And this is a picture of me when I was 2 years old in the main square. Around 95, 96, pro-communist forces wanted to see if they can reestablish the previous regime. And so they started to come after people who have been doing well since the collapse of the communist government in our country. And my father, electrical engineer, had opened up his own company and was doing quite well for himself. And so he became one of the people who they focused on. And so in 1996, we actually had green cards for the United States. And so we fled the country. We ended up getting in on one of the last planes leaving the airport before the airport shut down for a number of months. And we came to the United States with just 2 suitcases. And sort of that's where my story with Albania ends and my story with the United States begins. So to talk about neurosurgery residency in the United States, I figured I'd talk a little bit about how you get to that point. So the first step is finishing high school, which is a 4-year process. And during high school, you take the SAT test. And I just put up here, I did some research last year. The average score of people getting into college in the United States was 1051. And interestingly, getting into Ivy Leagues, the score was much higher, 1580. So I went to Brooklyn Technical High School, which is this very large high school in Brooklyn, just across the river from Manhattan. You can see Manhattan in the background in this picture, if you guys can see my my mouse. So after high school, I went to college, and in college, this is also a 4-year process in the United States. If you're interested in continuing on in medicine, you take the MCAT, and last year's average score of applicants going into medical school was 512. So I went to Cornell, which is just an absolutely beautiful campus in upstate New York. So, you know, I moved to New York City, and Ithaca, where Cornell is located, is in upstate New York at the bottom of the Finger Lakes. And this is Cayuga Lake in the background. It was just an absolutely amazing 4-year experience. So once you've taken the MCAT and entered into medical school, that too becomes a 4-year process. And in order to progress on into residency, you take the USMLE Step 1, which for last year, the average score for our applicants who successfully matriculated to residency was 232. So I went to med school at Dartmouth, which is located in New Hampshire. So once again, in the same general area of the Northeast United States. And then from med school, to get to end up as a neurosurgeon, you have to finish residency, which is now a 7-year process. And I'm at the University of Rochester, which, if you guys remember where Ithaca is located, University of Rochester is just an hour or so away from there, with once again, a beautiful campus right near a river. And so I wanted to talk a little bit about what U.S. neurosurgery residency looks like right now, before I talk about my own experiences. So as of 2019, we have 112 neurosurgery programs in the country for a total of 232 spots. In 2019, there was 341 applicants. That means that was a match rate of 67.7%. But that's not fully accurate because many of the applicants, before they get to the point of going for neurosurgery, self-select out or change their mind or have counseling to tell them otherwise to apply. So that number is actually held to be quite higher than 341. In the United States right now, there's about 1,500 residents. That body is made up of approximately 8% international, 17% women. And I found this interesting, about 2% attrition rate. So each year, about 2% of neurosurgery residents end up leaving neurosurgery for various reasons. U.S. neurosurgery residency has undergone major changes in the last 2 decades. Probably the most, one of the biggest was imposing an 80-hour work week. This first started in 2003, which essentially says that resident physicians can't work more than 80 hours in a week. And this has been a point of much debate within United States medical communities. In 2012, the American Board of Neurosurgeons introduced milestones, which is, I'll talk about this a little bit more in a couple of slides, but essentially they've set up the minimum amount of cases that each resident needs to finish in order to be deemed acceptably trained. And then in 2014, the American Board of Neurosurgeons made all neurosurgery residencies 7 years in length. And this requires at least 12 months of what has been deemed research. So looking at the structure with all these changes, through these 7 years, the first year is your intern year, where essentially you learn how to be a doctor. You learn how to assess patients, place orders, et cetera, your next 2 years, 2 and 3, you're thought of as the junior residents. And this is predominantly the years where you take a lot of primary call. So you're in the hospital, seeing consultations, sleeping in the hospital, et cetera. And most programs around the country don't have a lot of operative exposure for residents during these stages. Your 4th and 5th years typically thought of as a mid-level resident. As you progress through residency, you take less primary call and your operative experience increases. And then where programs across the country differ is where they built in this mandatory research time. Some programs have only 12 months, some have 18 months, some have 24 months, but no program that I'm aware of has anything longer than 24 months. So between years 4 through 6, you have sort of increasing operative exposure with a built-in research block. And then your 7th year is considered your chief year, where it's very heavy operative. So now to sort of go back to my experience so far in residency, and as I mentioned, in 2013, I think it was, the American Board of Neurosurgeons implemented these milestones, which is essentially what they want to see neurosurgery residents finishing with. And this column here on the left is what graduating neurosurgery residents for the year 2017 to 2018 had completed for all these various procedures. And this has to be at the level that we consider senior or lead resident. So essentially you have done a majority of the case or the critical part of the case. I've been very fortunate, and one of the reasons why I chose the University of Rochester is because even as through the first 5 years of residency, so with 2 more years ahead of me of my heaviest operative experience, I've actually surpassed the averages for most of graduating neurosurgery chiefs already, and I still have 2 more years to look forward to. So to talk a little bit more about this research block, many programs across the country have sort of allowed residents to tailor their research year according to what they want to develop themselves in. So many neurosurgery residents end up completing an enfolded fellowship. So that could be in endovascular or spine surgery, et cetera, et cetera. Some obtain additional degrees during that year or two. So MBAs, we have one resident who's done that in our program. Some are very interested in clinical research or basic science research. Some pursue international neurosurgery opportunities. For example, we have a cooperative with the Royal Melbourne Hospital in Australia, where we can spend 6 months there if we'd like, practicing as a junior registrar. And others, based on your interests, can go into anatomy research. So I just finished my research block, and I sort of really overachieved in some cases, and I did 3 things at once. So I went to Barrow Neurological Institute and worked with Dr. Hashimoto, looking at vitamin D deficiency in aneurysm rupture, which I can present in future meetings. I also did a research and clinical fellowship with Dr. Lawton, and I completed the Dr. Spetzer skull base research fellowship as well. So it was a very productive year for me. Some of the other experiences I've had as a neurosurgery resident, we in our department did not have a very good facility for anatomy training and learning. In fact, we had this space that was designed in the 1970s as a cellular physiology lab. And after about a year of pestering my chairman and wanting to do more with that, he finally gave me the support I needed to sort of completely redesign the space and make it into a state-of-the-art skull base and anatomy lab. So after many renditions, we came up with a final schematic of what the lab would look like. And so we underwent sort of construction, tearing down walls, joining into the adjacent areas, putting in all the appropriate installations and everything that we needed for the lab to be functional. And then this is the finished product that we were left with. These tables I also designed. They're fully mobile. They have Mayfield clamps, microscopes built in. We also have a master station in the back that is connected to the TV screens throughout the room. And so you can see whatever the proctor is doing. We have 2 new storage rooms where we'll thankfully received a lot of support from Medtronic to help make this possible in the form of equipment and otherwise, as well as a full prep room for whatever activities we have planned for the lab. So, and sort of finally conclude, I've taken on quite a number of other projects during my time. Something that was near and dear to me right from the beginning of residency is delayed cerebral ischemia. So I ended up starting a clinical trial, which is now multi-center, looking at lumbar drains and external ventricular drains to see if one method is superior to the other in reducing delayed cerebral ischemia, and I'm happy to present that in future meetings. I've also gotten a lot of interest in the test of thromboelastography. There's some proposed research that shows that delayed cerebral ischemia is actually a process of microthrombi formation, and thromboelastography is a very accurate test to look at the entire coagulation cascade and is very patient specific. So we've started that as well with the help of hemionetics. I'm now, given all the experience I've gotten from the clinical trial for lumbar drains and EVDs, I've started writing a book that's very much geared towards junior residents, critical care physicians, ED physicians, etc. And also I've been fortunate to receive grant funding and be productive academically with publications. So in neurosurgery, if you choose to go the academic route in the United States, many places look very favorably upon fellowship training. And so my love is cerebrovascular and skull base. And so my next steps are looking for and interviewing for open vascular fellowships as well as endovascular fellowships. And I wanted to conclude on sort of the lessons I've learned in residency so far. Regardless of how busy you are, there's always more sacrifice that can be made. And in order to achieve success, you have to be willing to do what 99% of other people are not willing to do. And so that does require sacrificing time outside of work that you would be using for family or other events. With that said, though, anything that you take on, I found it to be a lot easier if it's something that you're passionate about. It almost doesn't make it work. It makes it the drive to continue to want to explore further and further into what you're doing. And lastly, I think the reason why I've had the success I've had so far is really been about building bridges, collaborating with many people, and drawing on the support of so many mentors and models and other people that are not in neurosurgery in order to continue to push yourself forward. So that's my thoughts on residency, and thank you for your time.
Thank you very much, Dr. Reddy. Dr. Ishu, can call the next speaker before we go for our last questioning session.
Sure. Thank you, Dr. Reddy, for a wonderful lecture. And I would like to invite our next speaker, YNS speaker, Dr. Gratian Simbarase Guinero. He is a neurosurgeon from Harare, Zimbabwe, and he has been trained under neurosurgery at University of Zimbabwe, Harare, and currently he has published in a British Journal of Neurosurgery, and he has presented at various conferences, oral presentation and poster presentations. He has attended many courses. One was a WFNS educational course, AO spine course, WFNS live surgery seminar, and currently he is doing some good work to uplift the neurosurgery at Zimbabwe, and he has special interest in skull-based neurosurgery, for which he has dedicated his time and life. And I would like to invite Dr. Gratian Simbarase to present his lecture about neurosurgery training, experiences, expectations, and reality. Thank you.
Thank you very much. A good evening to you all. Hello, can you hear me?
Yes.
Yes, we can hear.
Okay, thank you. I just want to begin sharing my screen, and I just want to first of all thank Professor Yoko Kato for this gracious invitation for me to participate and share with you some thoughts from this side of the world. I would also want to thank my professor, who has been guiding me all the way until this day in neurosurgery. I'll just begin by letting you know that I'm a neurosurgeon at the moment. I graduated in the year 2018. That's when I finished my neurosurgery training after 5 years with the University of Zimbabwe, College of Health Sciences. So I was primarily based at a hospital called Parirenyatwa Hospital, here in Zimbabwe, in Harare, the capital city. So after those 5 years, I took some time to join Professor Ike Cherian in Nepal. I'm going to tell you a bit about that later in this presentation. So this is just a picture of the College of Health Sciences that we have in my country. And currently, there are 2 training programs for specialists in Zimbabwe, but at the moment for neurosurgery, it's just 1. So there is the academic track, which is mainly the Masters in Medicine, which I did a Masters in Medicine in Neurosurgery, which took me 5 years. Then there is another, which is the more of a fellowship, non-academic route, which is offered by College of Surgical Sciences, which involves several African countries, which is called the COSEXA. So in Zimbabwe, there is one during my time 2014 to 2018, there was just 1 hospital which was training neurosurgery at that time, and that was Parenyatwa Hospital. But we now have 2 hospitals, another central hospital here in Harare, which is called Harare Central Hospital, which has since joined in helping train neurosurgeons in my country. In Zimbabwe, we have, during my year, we had 2 trainees. It was me and another colleague, Dr. Nemayire. We had opportunities to also assist with training colleagues from neighboring countries, for example, from the Democratic Republic of Congo, Namibia, Zambia, and other neighboring countries here in Africa. So this was my class. This was when I started in 2014, and I'm seated in the front row seat on the right side, on the extreme right side, and on the front row seat there. And here, this was a combination of students in neurosurgery, also in general surgery, in neurology, and a few other specialties. So that was my first year, and here we're in the anatomy lab. So I just want to start by letting you know from my side here in Zimbabwe, Southern Africa, what exactly were the expectations when we began training. So in my first year of training, the first year mainly comprised of learning surgical anatomy, not just gross anatomy, but more specific, the surgical anatomy, which we are then expected to make use of now that when you're in the operating room and when you're now treating patients. So I spent 1 year dissecting a full body. I did dissections of all regions, but I then later in the year I concentrated on neurosurgery. But when I was dissecting the whole body, I was cognizant of the fact that I have to take note of the nerves that pass through the different regions, the major nerves or the named nerves. And we were fortunate in that we had guidance from a neuroanatomist, and we had neurosurgeons helping us, including my professor, Professor Gazadi Kalangu. In my second year, I took time to rotate in all other specialties that are related to neurosurgery. including neurosurgery itself. I took time to rotate in neurosurgery, just getting to know what neurosurgery is and what is done there. We had opportunities to be on the ward, learning about neurosurgery on the ward, and then you had to take time to go to theater and see what was being done there, which really prepared you for the third year as you started neurosurgery, as you began neurosurgery, dedicated neurosurgery. So I also rotated in otorhinolaryngology, that is ear, nose, and throat, orthopedics, maxillofacial surgery, a bit of plastic surgery, and I also took time to participate in pathology. Then my third year was mainly about neurotrauma and pediatric neurosurgery. So then my fourth year was spine surgery, and my fifth year was oncology and vascular work. So in Zimbabwe, for several reasons, we have a lot of trauma, and we have a high burden or a high workload of head injuries. So we get a lot of hematomas, whether they are epidural or acute subdural hematomas. We have quite a huge caseload of that. And in my third year, when I joined the unit at Parenyato Hospital, I just got there and I started doing trauma surgery. So I did a lot of epidural hematomas, subdural hematomas. I did a lot of depressed skull fractures, cranializations for frontal bone fractures involving the frontal sinus. Pediatric surgery came in the form of we see a lot of patients with hydrocephalus, pediatric patients with hydrocephalus, and also pediatric patients with myelomeningocele. We also see quite a sizable number of encephalocele. So I did a lot of surgery in that area, and I did much of it as primary surgeon, with, of course, with the supervision of my professors during that time. Then my fourth year involved a lot of work in spine, from degenerative spine disease to trauma. This excluded, of course, spine oncology. That was, we did that in my fifth year. So this takes me to my fifth year. I now focus more of my surgical duties on operating tumors and assisting in vascular work. So I started by mainly being the assistant in tumor surgery, and with the assistance of my tutors, I also participated in I was guided through tumor surgery. Vascular work for me was was one of the highlights of my training, because of the complexity of vascular neurosurgery. I must say, in my training, I did not have an opportunity to be the first surgeon to do any vascular work. I was more of an assistant, and but as time goes on, one of my desires is to do a fellowship in some vascular work. So I just want to go now to the actual training and the experience I gained when I was training. So, like I said, I had 1 full year. I'll start with the first year. I had 1 full year of dissections. The university provided us with enough specimens for each student to use. So we had specimens that already were dissected and were labeled. So we started with those, and we dissected with the assistance of a neuroanatomist, and we had we were using we had dissection literature to use, surgical dissection literature that we were using to do that. And then later in the year, we had fresh specimen to start to dissect through and to prepare it like the other specimens that had been dissected, labeled, and preserved for the other generations of the students that would come later. So I would say my first year was really was full of progress and very fruitful. Measuring it against the expectations. Well, my second year, most of the rotations were beneficial, though I picked out certain areas that I think we can always make changes in to make the training better. I thought that there are some areas I needed to spend more time in, and others that I needed to spend less time in. For example, I thought we would have desired, of course, to spend more time in the ICU, the intensive care, because we look after patients. We have a lot of patients that go to ICU, and a coordinated approach was one that when by the end of the rotation in the second year, we were now trying to work on for the other students that were coming after us, and also to standardize the rotations in those units. Sometimes you get to you rotate with let's say with the cardiothoracic surgeons, and maybe during that period they are focusing on open heart surgery, which to you, besides knowing about open heart surgery, you'd be more inclined to want to know about thoracotomies and approaches to the spine via thoracotomies, as an example. So these are some of the things I picked up that we then shared with the responsible authorities who were in the program. So in my third, fourth, and fifth year, like I said, we had lots of there was lots of trauma, which was really beneficial for us. That helped us to train our hands for surgery. And I would say many, personally speaking for myself, I learned a lot of surgical skills just by the volume of work that I did. I'll just share with you that I used to spend, I used to sleep at the hospital in my third year, 7 days. Sometimes I would have to sleep at the hospital for 7 days just to do some of the work. And then, of course, I would get some leave to go home. But I had, there was no lack of enough work. I think one of the things that we wish we could have done at that moment was to have dedicated neurosurgical theaters and a dedicated ICU for neurosurgical patients. That in itself, especially lack of, sometimes you find that ICU was a bit limited in terms of the beds. Sometimes you would hold on to some of the operations. And yeah, if we had more beds, I believe our work would be smoother. But those are some of the challenges we faced. But nonetheless, we were able to do our work well. I just liked the previous presenter who showed the neuro drills that they have for the laboratory. I hope one day, well, I hope soon, not far, we'll be able to do the same for ourselves. On another point, we had opportunities to collaborate as neurosurgeons in our region. We had the CANS, which is the Congress of African Associations of Neurosurgical Societies, which made programs available where we met, and we had a section for trainee neurosurgeons. And we had a lot of support. So this is a picture of me in the light shirt with some of the students that were training during my time. And these programs were really helpful for us. This is us at one of the conferences which we attended in Abuja in 2018 with one of the eminent professors from Africa, Professor Owae Gubalam, in the middle there, who helped us in our training also. When I finished my training, I recognized the need for further strengthening my skill. So once I had finished, I had the opportunity to join Professor I. Cherian when he was still in Nepal, in Biratnagar, at the Nobel Medical College. And there he was doing, like he's doing now, he was doing a lot of work on skull base, especially skull base oncology. He was doing a lot of work on vascular neurosurgery. So I joined him, and he spent some time there with him, and in the better part of 2019, and he took me under he mentored me in skull-based surgery and vascular neurosurgery. And one of their particular lessons I took home with me when I left Nepal. Number one was the determination that he had. Nepal is not one of the richest countries. In fact, at one time it was said to be one of the poorest nations. Just quoting some, some reports, but they were not even in the capital city. But they had so much determination. They set up a very, actually I would say a world-class neurosurgical center. They were trailblazing. They were setting new frontiers, and they were unconventional in their approach in neurosurgery. And I took these lessons home, and I have so far been trying to apply them. So this is us with Professor Ike Cherian in Nepal. That's Professor Ike there. That's me. These are some of the students that were with him at that time that I joined. In Nepal, I did a lot of dissections. I think that's one of the things I did most. One of the things I did, I benefited a lot in. Professor Ipe was taking me through dissections every day, and they bought a specimen for me, and every day I was required to spend hours doing dissections. So these dissections were structured this way. I was doing surgical approaches for example, the terminal approaches, and I had to learn the retrosigmoid approaches and many other approaches, the FTOZ approaches. So we had a Leica F40 microscope. and that's what I used. I also spent at least every day I had to spend at least 2 hours doing microsurgery. So I had to fulfill that in order for me to for this period to be beneficial to me. So this was us with Professor Aicharian when we were doing a pineal region tumor. We were doing a supracerebellar subtentorial approach. That's me and Professor Ike, and one of the ladies there. This lady is actually a neuroanatomist. She took me through the dissections. She was my teacher during the dissections, and that's me receiving a certificate at the end of my time with Professor Ike Cherian. My concluding words are that the best way I learned to improve your skills as a neurosurgeon, even after you have finished training, is collaborations. And I still continue in that spirit of collaboration. Right now, I'm working with Professor Kazadi Kalangu. I'm actually, I would say, underwriting Professor Kazadi Kalangu. We are now working together full-time in Zimbabwe. So I'm benefiting from skills transfer from him. The journey is still long. I still have more fellowships to attend, more research work to do. And with this, I would like to say thank you to you, Professor Yoko Kato. Thank you, Professor Kalangu, and thank you all for listening to my talk. Thank you.
Thank you very much for the talk. We have 10 more minutes left before we are going to close our session. It's open for question now. Anyone have any question?
Can I ask, please?
Yeah, sure, Professor.
Can I ask the first speaker? His name is ready. Is okay? So
yes.
so you want to become a hybrid neurosurgeon. So that means you want to do the both endovascular and also the open surgery. In Japan or China, most of the younger generation have both techniques. So they can decide the indication, the treatment by themselves, even the on duty time. I think it's very, very important, I think. So I don't know the system in the United States. So the endovascular, how because sometimes the radiologist can taking over the endovascular. So what the situation in the United States now?
Thank you for that question, Professor Council. That's essentially the case, is that here endovascular is a combination of neurosurgery, radiology, and neurology, all vying for the same. I may be biased, but personally I think that neurosurgeons are best trained or best equipped for that, just because of exactly as you mentioned. I think we understand the anatomy better because we work with it better. So we can more readily push for one approach versus the other that would most benefit the patient. It's no secret that there's definitely some indications that endovascular is superior to open surgery at this point, and that will continue to increase. And so being able to have that repertoire is, I think, tremendous for the patients. If you're coming at it from, the argument is, if you're coming at it from just a one-sided approach, you either have to have the humbleness within you to be able to realize that what you are offering may not be the best for the patient and refer that patient to someone who can offer that, or you're not necessarily doing the best thing for the patient. So having training in both, I think, is ultimately the best thing for the patient.
Thanks so much. Please, Prasad. Good evening. How are you?
How are you? Thank you. And okay, I like to say condolence for late Professor Tsokano. He was a great man, and I remember we are very sad in Afghanistan, and he was kind about our people, our young neurosurgeons, and rest in peace.
Thank you so much.
Would like to follow his way. Okay. Thank you.
Thank you very much. And arigato.
Arigato.
Family, yes. Thank you.
Okay.
Ready? Can I continue with Professor Kato's question? Do you consider ischemic stroke to be part of the job?
This is a point of contention, I think, in the United States. You know, as much as I want to keep endovascular strong within neurosurgery, just as you mentioned, carotid disease is being shipped out to vascular surgeons. So we have to fight on all fronts to keep disease of the brain to neurosurgery. And so it might be controversial, but one of the things that has been talked about is making sure that every neurosurgeon that graduates in the United States knows how to fix a broken back, knows how to fix a broken skull, knows how to fix a broken shunt, and can do a stroke. So I think ischemic disease, vascular, far outweighs hemorrhagic disease. And so we stand a real chance at losing ground if we give that ischemic disease away to other specialties. Because with ischemic disease comes all these other pathologies that we find, you know, whether it's aneurysms, AVMs, fistulas, et cetera, et cetera.
Thank you.
So can I ask the guy from the Zimbabwe? So thank you very much for a nice presentation. But you studied the Ipcherian phase. That you were very lucky. So your teacher, there was Ipcherian because he is very talented, the neurosurgeon. So, but still, I think after the trauma surgery, so maybe you can keep the patients under the ICU. So do you have some such kind of the training for the monitoring, or how you can better condition of the patient after the surgery?
So we do not have any particular training in neurocritical care. That's one of the areas that we realized needed to be included in the training, because we have a lot of trauma patients and a lot of head injury patients. So we don't have that one. That is one thing we really have to introduce into our training so that we are better equipped. We have intensivists. Those mainly have been the ones who have been looking after our patients. But of course, with our input also, because there are some things that definitely they need our guidance in. Yeah.
So does Vladimir any suggestion for him? Vladimir?
Sorry, Vladimir.
Emil, you give him some suggestion?
I didn't catch what you were saying.
Because after trauma, the surgery, so how they can keep the patients, how that they need some training, intensive care training, I think.
Yeah. Gracian, do you remember we were there some 3 years ago in Zimbabwe? And along with Yoko, and it was a great experience. And you know what surprised me most? While thinking the OR, we were sitting in the recreational area. And there were guys from cardiothoracic surgery and from other surgical disciplines And I was amazed how well educated they were. You know, their knowledge was amazing. Yoko, do you remember that? It was
Yes.
amazing that these people knew everything. That was real perfect.
So I think you should study, I think, and also maybe you can go to the big center, please. So the trauma disease is a kind of very complex, very difficult. How to manage the after surgery, I think.
Yes. Definitely, yeah. That's I think one of the plans that we had as a unit is to train a lot, to have subspecialty fellowships in different areas, and one of them was neurotrauma. Fortunately, in Cape Town, which is near our country, we can go there for further training in neurotrauma. So I think that's one area that we will consider just after. We hope the borders will open soon so that we can do that one. But in the meantime, we can always use the available facilities to learn, even with the available doctors in our country, because we have intensivists that are quite that are good in these things, even and like Dr. Vladimir said, the other colleagues, yes.
So Dr. Liu, some suggestion for both of them?
I think South Africa is a good option. I think you have many great professors there. And other country, I think where handle a lot of trauma, as I know, is India, China, and probably in other Southeast Asia countries. We have a high number of head injury, and we do treat them in intensive care unit. And I think there's a lot of research going on even in China. Probably Professor Chen can give us some info on how well they have a critical care there. Professor Chen?
Yes, I'm here. I think we welcome you come to here and join our neurosurgical trauma program. In China, we have different subtype program, neuro-oncology, surgical, general neurosurgical, and trauma, only trauma, different group. Those doctors only work for neurotrauma and only for sorry. Excuse me. Yeah. Sorry. Sorry, I'm in the coffee bar. Yeah, and some group doctors only work for brain tumor, and some only for pediatric neurosurgery. So we have different central and group. In the bigger hospital, we almost have all of the subgroup. In some hospitals, such as children's hospital, they only have pediatric group, but the pediatric group can work for neurotrauma, brain tumor, and vascular disease. Oh yeah, I forgot vascular disease. And in China, to me, my specialist pathway is very special. I was in general surgery, then vascular disease surgery. Then I joined the neurosurgical program. Yeah. Now I pursued my interesting. I love work for brain tumor and the neuro-oncology. So I trained for neuro-oncology almost for 2.5 years. Not only for surgical work and also working lab. I worked for clinical trial. Now I'm working in professor, work as a assistant professor, major for the research. This is my choice. But if you like work in the clinic, you still only can work in the clinic. We have a training program for neurosurgery. You have to apply for this. I can ask for you if you have chance and opportunity and how to apply this program. This program almost 3 years. For 3 years, you can work not only in the surgical room, and also you can work in the ICU. We have special team only work for ICU. I work follow the neurosurgical work in Shanghai Renji Hospital. This hospital is famous by neurotrauma. You can search the professor named Jiang Jiyao. Jiang Jiyao. He published many articles for neurotrauma. So he's very famous. And he also do a clinical trial for neurotrauma. And he published the articles on New England general surgery. So very famous. I think he will welcome international student or trainee come here. Yeah.
Maybe
maybe you can send me email and we can make a network and connection. Okay.
Yeah, that's great.
Do you have any question?
I have a remark on trauma. Gracian, what we see here in Europe, and I believe it is the case of US and Japan as well,
really?
is decreasing number of trauma. Sorry?
Sorry, Dr. Vladimir, please continue.
It's decreasing number of traumas, very rapidly.
Okay.
And something which got nearly extinct is pediatric head trauma. We do not see any. People are safer, and I believe that this trend will come to Africa, Indonesia, and other countries as well. In some faster, it comes slower, but that's the general trend.
Thank you.
Wait a moment.
Just one option you can, if you have a chance, just you can go to China, because China has a lot of the trauma still.
Wait a moment, I have to leave.
True.
And
yes,
China
so
does.
maybe I can introduce her, or you can make some network among the younger generation. Yes, that's nice, I think. Thank you so much. Wonderful presentation.
Thank you so much.
So I and Vladimir, maybe we'll visit your place once again.
Thank you. You're welcome. Most welcome.
Yes.
Thank you very much. I think it's time for us to end our session. May I ask upon Professor Kato to give a closing remark, Professor?
Maybe Vladimir, maybe you can make some closing remark, please.
Yeah. Well, I love these activities because I believe that they are really valuable. That's a direct teaching, which is somewhat hindered only by the distance, but the advantages are extraordinary. It's for free, no travels, no hotels, no flights, no nothing, and young people can see anything. And I really believe that this activity will survive COVID, that we shall keep on this, and that especially ACNS, which is thanks to you, Yoko, that active in this activity, that you just will go on and continue organizing these focused seminars, which are really a new pearl in neurosurgical education.
Thank you very much, Vladimir. To tell the truth, because Vladimir presented from the early in the morning, so we woke up him. So he was still in the bed at the time. So, but he tell us so many talks. Thank you so much. And I think maybe we cannot do the real hands-on, but the Dr. Wada showed us about nice hands-on of the CEA, I think. Or sometimes we can show the video. So I think this kind of the webinar, I think it's very helpful for your study, I think. So, but the 3 hours is too much, I think, maybe. So make it a little bit short. But I think it's very helpful and very fruitful, the webinar tonight. Thank you very much for all speakers and the commentators and the senior professors, just like Vladimir. We are very grateful you're joining tonight. That is my conclusion. All the best, the guy who is working in the United States. I've never been to Albania, but Dr. Arion, he used to be with us long before at the Fujita Health University. That he always showed us how nice of the Albania. So
it's very beautiful now. It's very beautiful now. You must visit.
We should have proud. Thank you very much.
Thank you.
Yeah, we should organize that. Kado, Reddy should join us from US. And everybody.
Oh, you're there. Can you tell one thing?
Yes. Hello, everyone.
Hi. How are you?
Well, I miss you guys. My apologies, I couldn't join earlier, but I guess we had the best representatives to present some work, and I look forward to having you visiting Albania. Things have changed. I agree with Reddy, although I haven't been quite there every year. But it'd be great to organize something in the near future where we can be present physically. It seems things are taking the right direction now. So I look forward to that. Thank you.
Thank you, everyone, for joining tonight. Thank you so much. I don't know, what time is it in the Toronto?
Well, currently it's 9:40 in Toronto. That's where I am right now. Thanks. Yes.
Okay. Not so bad time. Thank you very much. So, Dr. Liu?
Yeah, thanks to everyone. So we're going to close the session. We're going to meet again next month. Thank you, professors. Bye-bye.
Thank you very much.
Thank you.
Bye.
Have a great day. Thank you. Good night. Vladimir, thank you so much.
Thank you, Yoko.
Bye.
Pleasure.
Bye-bye. Thank you, Dr. Kado.
Thank you, Chen.
Bye.
All the best for your oncology study.
Yeah, thank you. Sorry, I lost my sound in the channel. Okay.
Oh, sorry for that.
Yeah, I can.
Thank you very much, Professor.
Bye. Yeah.
Bye. Thank you very much for a nice MC tonight. Thank you.
Thank you very much.
Dr. Singh Bashu, do you keep my email address? Hi, Grantian.
Yes, I saw your email. I saw the email.
Oh, okay. I think when we leave the Zoom, everything not to keep. Maybe
Okay.
you. Okay. Bye.
I'll communicate on WhatsApp, on email.
Okay, email me. Bye.
Thank you. Thank you, everyone.
Thank you, everyone.